Hello everyone. Welcome once again to yet another insightful episode of our podcast, an initiative of Madras Orthodontic Study Group. And this is Dr. Rekha Bharadwaj here, convener of the study group, extending a warm welcome to one and all. This initiative of podcast is a powerful platform for learning, sharing ideas, and inspiring conversations. I'm truly delighted to feature an engaging discussion between our distinguished guest speaker, Dr. Narayan Gandedkar, Program Director in the University of Sydney, Australia, whose experience and expertise has definitely have a significant impact in the field of orthodontics. And not to forget our accomplished interviewer, Dr. Srirengalakshmi, Professor in the Department of Orthodontics, Savitha Dental College and Hospitals, who will guide this conversation through thought-provoking discussions. I hope you all would enjoy this enriching exchange and take away some valuable perspectives from today's episode. Over to you, Dr. Ranga.
Everyone, I'm Dr. Srirengalakshmi, Professor at Savitha Dental College, and I'll be your host for today's podcast session, which is an initiative by the Madras Orthodontic Study Group. And for today's session, we have with us the one and only Dr. Narayan Gandedkar from the University of Sydney. So what are we waiting for? Let's get started and let's hear it from the horse's mouth. So, hello, Dr. Narayan. We welcome you for the show.
Hi, Shri, how are you?
I'm good.
Yeah, thank you so much. And thank you so much for Madras Orthodontic Study Group, as well as the convener, Dr. Bharadwaj, for having me here. I'm grateful.
So let's get started. Dr. Narayan, you've worn many hats throughout your professional journey, like a clinician, academician, researcher, leader, mentor, and many more. So if I were to take all those hats away and let you keep just one close to your heart, which one would be that? And why?
Well, right. Okay. So I think it's a combination of academic and a clinician, because we as orthodontic professionals, I don't think we can separate ourselves as being academics alone, because as long as you are a great clinician, I think you can put forward your academic career in a better way to your own students. Yeah, it's a combination of both. I can't pick one against the other.
All right. And on a lighter note, I know there's one particular hat that is close to your heart, which is the chef's hat, and I'll save it for the end of the session.
Right.
So let's start with the clinician. So, for many orthodontists, the surgery-first orthognathic approach, the SFOE, is no longer a new concept. Yet, it continues to evoke equal measures of fascination and hesitation. So how did your own journey with SFOA begin? And what convinced you that surgery first was merely not feasible, but in selected cases, perhaps preferable?
Right. So if I look back on my own journey or kind of reflect upon it, I think it all started when I was in 2007 or 8, year 2 or year 3 postgrad. There was this paper came on surgery first, a paper written in Journal of Clinical Orthodontics, how to approach some of the cases which you feel that you are doing or slated for jaw surgery. Can surgery first be an option for those kind of cases? I mean, that was the kind of, it got me into that mode of thinking that there's some approach called a surgery first as well.
Absolutely. So I think despite the growing scientific evidence and the popularity of SFA, there remains a certain reluctance amongst the orthodontists to embrace SFA. So does this stem from scientific concerns, logistical challenges, or just the discomfort of moving away from a familiar treatment protocol? So what do you think it could be?
I think it's fair to say or assume that the conventional orthodontist or the regular orthodontist would like to see their patients, if they have seen or doing orthodontic cases that require jaw surgery, they are a bit skeptical at the moment. I mean, you rightly put forward in 3 different scenarios, whether it's heavily evidence-based, or is it the logistics, or is it the combination of logistics, evidence, and also can we do it with a team which can pull off this kind of surgery first approach? I think it's got to do with all 3 in one go. And also the hesitation of learning something new, because surgery first, although it's been there for a while, but if an orthodontist has been practicing jaw surgery in their practice, most likely they would have done the conventional way. That's what I'm saying. It's new in comparison to the conventional way of doing it. And they would want to know, they're curious. They are like a cat on the wall at the moment. They don't want to jump on the surgery first side, but I think they are curious to know what exactly surgery first has to offer. But having said that, the biological aspects of it is come to a point where fundamentally surgery first is now gone beyond crossroads of how it can be approached in terms of the biological underpinnings. Logistically speaking, it has evolved quite a bit. I think if I draw back to my own experience of 2009 or 10, this is 2026. So logistically speaking, the technology has improved. The way we understand techniques has improved, not just in conventional, but in surgery first as well. So I think it's a combination of all of it. The orthodontist must find a good surgeon as well who it's the other half of it, where they are also happy to go about doing surgery first. So yes, it's at crossroads at the moment, but I feel that moment will soon eventually cross over and become a more substantial way of doing surgery first for most or large part of orthodontists.
All right. Like you rightly mentioned, we have to find a good surgeon and an orthodontist. So pertaining the discussion to that, I think I want to know, like, how important is teamwork in the success of a case? And do we need a good team or a defined protocol or a shared treatment philosophy? So which one do you think would play a dominant role?
I think teamwork is the most important aspect of all of it. I think you have seen it. You have been into surgery for a longest period of time. Any person who is involved in large share of burden lies on the other half as well. I think it takes a good team for them to get to the finish point. In terms of understanding the complexities, yes, both needs to share the burden, the orthodontists and the surgeons, in terms of applying their techniques. What can be achieved or what can be achievable or not achievable also depends on the orthodontists and the surgeons. And also the complexities. I don't think you should, as an initial or the beginner in terms of a team, as an orthodontist and surgeon, you don't have to jump into very complex cases. If you really feel that this is a new terrain, I need to kind of test my waters before I jump into it, probably start with the simple cases that can give you some confidence to begin with, and hopefully they will dig in deeper as they go along with it. Yes, it requires some amount of expertise from both sides of the aisle.
Of course. And you correctly pointed it out, start easy and go towards complex cases. So that brings us to the discussion. We are always at a fix. When to do it camouflage, when to go for surgery. So where exactly do we draw the line between a camouflage approach and a surgical approach? And is it dictated by the patient's need or the patient's desire, or it should be a balance of both?
Look, for me, it's the most important as if the camouflage line of treatment is bringing about a good value added, thing for the patient. Are they getting enough from that camouflage line of treatment? I'll give a classic example that usually borderline cases are the ones that will be in crossroads between whether you want to do a full-fledged surgery or you want to do a camouflage. Probably if you consider the aesthetics part of it, probably the functional goal of that patient in terms of the chewing, mastication, and are we not compromising the respiration or any other functional needs of that patient. Camouflage line of treatment would bring about some amount of respite for that patient. But having said that, you as an orthodontist, you as a professional, your primary goal should be to give the best to the patient. Usually borderline cases are the ones which will kind of make that questionable remark for yourself whether you want to do a camouflage line of treatment or surgery. In terms of surgery as well, all said and done, although it might bring you great aesthetics, great outcome in terms of the functions, you got some great set of teeth and all that, but you should not forget the fact that it is a major surgery. It involves finances. It might incur a great deal of burden for the patient itself. So in those cases, borderline cases, I would say 50-50 chances. Talk to the patient, have a conversation where respect the autonomy of the patient, make them aware that when they make a decision that this is the line of treatment that is best for both of us in terms of what we can achieve or what we can't achieve, to be precise. If they agree to it, if you agree to it, so be it. If the patient says that I want to do the camouflage line of treatment where you are as a professional, you want to do jaw surgery because this is more beneficial, then I would say that as a professional, you advise them. Probably it's not wise to go the patient's way just because the patient wants it, because they may not understand the full implications of what they are choosing or picking up. So yeah, I would say camouflage line of treatment would be more beneficial in borderline cases, which if you weigh in the surgical aspects of it, the morbidities associated with this, the cost associated with it. And also, having said, make a fine line, make a fine decision, be a professional and tell them the way this has to be told, and try to maintain the autonomy of the patient whilst your professional's advice is taken into consideration as well.
Yeah, because I'd also like to add that we are currently heading towards a very glamorous world where patients come with a certain kind of expectations because of the glorifications from the social media and the instant expectations. So I think as orthodontists, we still need to respect the envelope of discrepancy and make our decisions. And we should also be aware that we are shifting from hard tissue paradigm to a soft tissue and now more towards a patient-centric paradigm. So your thoughts about that?
The soft tissue paradigm, you're right. It was there for a while, at least as far as I remember, in the early 90s, probably around 1993, if I'm not wrong. There's this classic paper came out in terms of the 19 facial keys for planning, orthodontic surgical planning by Arnott and Borsman. If you look at it, the concept was floating around. I think these two gentlemen kind of hit the nail where it has to be. And then they told that the paradigm is shifting now. There's no more skeletal approach or putting the teeth and then looking for the face. It eventually kind of became more concrete in the early 2000s. And then eventually we are living in a paradigm where soft tissue structures needs to be kind of respected and given more priority rather than the hard tissues. I don't know how you look at it. I'll give you a classic example, at least over the years, what I've learned. A very aesthetic face, soft tissue, what we are looking at externally, barely has a very bad teeth or a very bad malocclusion or a very bad skeletal set of jaws. I don't know whether you agree or not. They look very pleasing, regardless of gender. They look very pleasing, right? If you ask them to open the mouth and take an evaluation of it, their teeth look pretty okay. And also their skeletal structures also look okay. That means that aesthetics has always been driving us. It's just that we were looking in the other side. We were looking from inside to outside up until 90s. At least that's what I believe. Nowadays we are looking at it more like from outside to inside. I mean, that patients don't walk around with teeth or skeletal structures. They need the face to talk and breathe and have a social conversation. Yes, the paradigm is currently, or I think it will live as long as the orthodontist profession is there, that the facial, especially the soft tissues, must be given priority when you're doing the planning.
So I think we've got a fair discussion about the paradigm shifts. So moving over with the toughest nut to crack, that is the class 3 malocclusion. I know it has fascinated us for many generations. And can we really tame the class 3 beast? Or does a successful management require a combination of meticulous planning, clinical acumen, the experience, and hard work, and perhaps a few prayers also?
I know, the prayers, I think you should put it as first, I guess. Right, so jokes apart, class 3 has been the forefront of surgery first. I'll give you my reasoning. I don't have any concrete evidence to suggest that. Why? Because class 3 is, in terms of the execution itself, most of the papers or most of the proposals have come from Asia Pacific, where namely Taiwan or Korea or Japan, they are predominantly they have class 3 patients, right? So that means that whatever their approach was very much curated to their own patients, which are class 3. So they have got a kind of phenomenal experience in terms of executing a surgery first approach in terms of class 3 patients. I think that evidence is there, where large amount of papers or evidence comes from that part of the world where predominantly the demographics define their population to be more of class 3s. That's one. Number two is class 3 is a little bit more easier to execute in comparison to class 2. Why? Because if you start with the simple cases, you don't have to worry about. I'll give a comparison of class 2 and class 3. Class 3 is more about mandibular setback. If you use a very easy case or a moderate crowding case, there's not much to decompensate. There's a flat curve of SPE. Or in terms of the dento-alveolar proclination itself, you don't see much of this complications as you see in class 2. Whereas in class 2, as opposed to the class 2 division 1, if you picturize, it's a combination of dento-alveolar proclination. Large portion of class 2 might evolve from a prognathic maxilla and a retrognathic mandible. Usually they require a 3-piece osteotomy of the maxilla itself. That complicates a little bit in terms of surgery first itself. And also you have to advance the mandible to the tune of maybe 8 or 9 millimeters in order to correct the class 2 skeleton to bring about the objective of doing it to a class 1. So that means that the stretch of the soft tissues is phenomenally as compared to the mandibular setback do in the class 3s. So probably in those cases, your condyles might not be seated in the fossa properly, or probably there is not much enough experience in terms of approaching a class 2 in comparison to the Asia-Pacific region's class 3's large volume of patients. I think it's a combination of both. But having said that, the world is now kind of warming up to class 2 approach as well. We see several papers from Europe. A large portion of South American orthodontists or surgeons are approaching class 2s. Probably in the coming decade, we will see a greater understanding of how class 2s are unfolding itself when we have this surgery first approach. Yes, phenomenal evidence lies in class 3s for now, but I think we have to wait for class 2's approach, how it unfolds in the coming years.
I think you rightly put it, the stretch of the soft tissues is something that we should respect. So beyond aesthetics, do you consider any other significant advantage that we have with SFA? Like, does it reduce the overall treatment time, or it just redistributes the treatment complexity?
Aesthetics is something that is been explored in surgery first in comparison to conventional. There is no doubt that it does bring about aesthetic correction right from the beginning of the treatment itself. No doubt about it. Second thing is whether it can reduce the overall treatment time in every case that we do. Definitely it won't. Surgery first is not a magic wand. You have to understand that part. Surgery first is something that it really takes into account the systemic axillary phenomena, which is regional axillary phenomena, and helps to move the teeth a little bit more faster than that of the regular orthodontic treatment. But that lasts only for about a couple of months. That means that you really need to be very clever enough to understand where exactly this wrap has kind of elicited which part of the jaw, which part of the arch, which part of the dental component. And then you have to work around it. So that means that you've got this very limited period of wrap effect unfolding itself after surgery. So you won't be getting that for the longest period of time. So if you have a very complicated case, you have extracted and then did surgery first, that means that it's going to last for 3 months, and then the wrap will kind of dies down after 3 or 4 months, and then regular orthodontic tooth movement kind of perceives itself. So it is not to be seen as an entity where all orthodontic cases subjected to surgery first will finish faster treatment. No, it's kind of disregarding what surgery first offers rather than giving it over-claiming things,
I know. I think these days people overemphasize the regional axillary phenomenon, rather than keeping it in between. So what are the recurring concerns that relates to the stability of the treatment?
Well, when it comes to stability, the one thing that comes to my mind is the seating of the condyle or the temporomandibular joint. You have to understand the difference between centric occlusion and centric relationship. Now, in surgery first, centric occlusion is kind of almost disregarded. So that means that what are we left with? We are left with centric relation. Centric relationship is the relationship of the temporomandibular joint with the midcranial fossa where the glenoid fossa is situated. So that means that the entire emphasis must be placed on the seating of the head of the condyle into the glenoid fossa without any undue pressure on the head of the condyles itself. There's no overstretching, the condyles are not pushed or pressurized to be seated there. If you pay attention to that part of it, centric occlusion is something that we can manage it in transitional phase of occlusion that we set up during the surgery first approach itself. So if you ask me where exactly the stability lies in the proximal aspect of the osteotomy cut if it's a class 3 or for some reason we need a BSSO, the whole ascending ramus, the head of the condyle, as well as the glenoid fossa. The centric relationship must be respected at all the times and taken into account as the key important aspects would be the seating, not to stretch it too much, not to forcefully kind of jam pack it into the head of the condyle. And then you realize that after a month or maybe in a week or 10 days, then you have a massive open bite, which you didn't plan for. That has got nothing to do with centric occlusion. That's a pure entity where centric relationship has been violated. Yes, and also the stretch of the soft tissues. Don't go beyond certain limits of doing your jaw surgeries. Conventional lower surgery first, it has its own limits. You can't be stretching the soft tissue and say that, oh, I'm gonna pull this, be great at it. No, it's not gonna happen that way. I can assure you that much.
All right. I think irrespective of conventional or SFA, I think when we respect the proximal relationship, I think that leads to, more success of the treatment. So do you encounter complications more frequently in SFA or conventional in comparison to conventional? Are they because of the different protocols or because simply different in nature? So can you throw your experience into it?
Luckily, I haven't, fortunately enough. Why? Because I think I got a very close observation while I was in Taiwan. Probably I was close to 200 surgery first when I was there in Taiwan for roughly 2 years. So that means that being exposed to all sorts of things. I mean, they saw a lot of complications where things were happening to them as they were trying to learn or get a grasp of it, because they were the early birds, if you ask me, the Taiwan group, In my own personal experience, I think I've encountered twice. One is where I think it was because I became over ambitious. It was a large mandibular setback, and then the surgeon and we did a couple of surgeries, and then we realized that let's take it on and see how this is going to go. It turns out that I think I explained a couple of minutes ago that we did not respect the head of the condyle positioning, stretching of the soft tissues, and there you go. After 4 or 5 days, you got a massive open bite, which wasn't planned out. And I can tell you in a heartbeat that this is seating of the condyle, and my surgeon was raising her eyebrows like, did we stretch it out to such an extent? He was clever enough, he was kind enough, and he took it back to the surgery, and there you go. That was the case, the unseating of the head of the condyle. It was always in the articular eminence. If you took the CBCT, the head of the condyle was kind of pushed out, popping out almost like an open bite case, because the head of the condyle was almost touching the articular eminence in the anterior glenoid fossa. Yeah, that's one. And number two is usually in class 3 patients, what I do is, this is a trick that Eric Liu taught me, is if you anticipate a bit of a stretch of your soft tissues, it's wise to give them chin cup therapy after the surgery, so that you kind of help that stretching of the soft tissues to kind of relax to a new position. Now, what happened was that surgery went on for a longer period of time. There was a bit of a bone to be removed, and the patient has got massive swelling of the soft tissues. And I couldn't place that chin cup because he was kind of still recovering pain, discomfort, and all that. And I let it go. And I called her back after 2 weeks when the face swelling had all gone. And then I realized that the mandible has relapsed. Probably it was because of the soft tissue stress. So I think the meticulous treatment planning and what are you expecting and how much you want to execute these things that you have already been knowing about, like seating of the condyle or putting a chin cup therapy immediately in order to kind of prevent the soft tissue stretch. Those kind of things must be taken into account. Yes, there are complications, but fortunately, I don't have many.
Yeah, I think open bite post-surgery is one of the worst nightmares an orthodontist and an oral surgeon can have.
Yeah.
So ignoring the complications, we do bring in a transformation to the patient's lives, How good is the quality of life, or how have we touched upon certain lives of patients where, it has transformed them completely?
See, the quality of life, there is no hard evidence to suggest whether the quality of life has been massive or statistically significant improvement in terms of the comparison between conventional surgery. I'll tell you my own experience. I'll give you 2 or 3 scenarios. The patient is about to get married in another 8 months. She already saved a lot of money to get the surgery done. She has gone to another orthodontist surgery group. They said that it's going to take at least 1.5 years for her to decompensate, and the surgery is slated to be 2 years from now. Disappointed, I looked around, okay, let's go to him and see what happens. She came in and then like, okay, you can do the surgery whenever you want. When you want it, 3 months from now, okay, let's get this done, right? That's the quality of life that I'm looking at, because they are excited about it. They get that surgery done. There's a massive improvement in their facial aesthetics. They're psychosocially, they become very outwardly going person, because they were always hiding or trying to see whether they can camouflage their deficiencies one way or the other. So that brings you a good quality of life, good outcome in terms of how they look at it. Number 2 scenario is the patient, nowadays I'm doing that for temporomandibular joint disorders as well. So the patients that get offered this kind of treatment is they usually have got this temporomandibular joint rehabilitation. That means that they remove the temporomandibular disordered joint and then they reconstruct it. That means they require some amount of aesthetics plus the rehabilitation of their jaw as well as the occlusion itself. In those cases also, they were like, I couldn't chew, I couldn't eat properly. They resolved their TMD's problems. And also within the period of 6 or 7 months, their occlusion is also settled quite nicely. So there is a good improvement of quality of life in those cases as well. Yes, in terms of the outwardly, the social impact, they can choose whatever they want without having to hesitate that I have to postpone my wedding date to another time, or TMDs, somebody told them wait for a longer period of time because we have to decompensate these teeth and then get a proper occlusion. You can skip that, do the surgery first, and then take the wrap into effect, and then finish the orthodontic part as soon as possible. Yeah, that's where the quality of life I see as a massive improvement in terms of surgery first.
No, true. I agree to that, because in some parts of a place, surgical orthodontics is very synonymous to marriage orthodontics. So, and post-surgical orthodontics is also very motivating, because you also observe that the patient is transformed in the way of how they dress, how they smile. That's a pleasant experience for all of us. So, having had enough discussion, now I'm going to have a rapid fire round for you. So you have to answer whether it's a myth, fact, or depends.
Right.
The first one, RAP is the primary reason why SFOA works.
Yes, it's a fact.
All right. SFOA always reduces treatment time.
It's a myth. It depends on what you're looking at, what type of malocclusion.
Okay. SFOA is more stable in class 3 than class 2.
Current evidence suggests that. Class 2 doesn't have much evidence, but I'm not going to say anything more than that.
Okay. SFOA has more complications.
You put me in a fix now. Depends.
So when you see a class 3 profile, what is the first thing that your eyes look for?
The frontal chin asymmetry and the profile. There's something called as gnathic profile field by A.M. Schwartz. I'm looking at the Pogonian projection. in the profile view. And the frontal, I'm also looking at the chin asymmetry.
So in general class 3 cases, what all you look for, like when you're observing a case for the first time? I know you have a hawk's eye, but how can you tell us like how you finish your clinical examination?
Right. So in the frontal view, usually, again, as I said, I'm looking at the chin projection as well as the asymmetry, which this patient has it. And also in profile view, I'm looking at the classic definition by A.M. Schwartz in the 1960s. He gave something called as GPF, Magnetic Profile Field. It's a very simple observation. You have to train your eyes in order to draw two lines, true vertical line. One drops from the nasion and other from the orbital, right? And you have to put that chin projection, which is the pog, between those lines. Now, if it gently touches the true vertical line, which is dropped from the nasion vertical, if the chin touches gently to that line, for a male, it's quite on point. You don't have to do a jaw surgery for that patient. If the chin projects further than that, probably you have to evaluate whether this is a case for a jaw surgery or not. Whereas in the females, orbital vertical line, OVL, is the reference point. If the OVL and the chin is very close to each other, probably they are in the range of normal chin projection. If it goes further than that, probably that's the time when you have to think about whether it's ideal for you to do a jaw surgery in those cases or not. In the frontal view, again, I'm more into lower anterior face height, how it's in terms of the rule of thirds, upper, middle, and lower, as well as the chin projection. I usually draw another visual imaginary line from the glabella to that of the philtrum and the chin point to see how much of the chin has deviated from the true vertical or the mid-sagittal plane.
All right. So when you see an asymmetric case, so does SFOA cross your mind, or how do you go about working on asymmetric cases?
Yes, this one, and there's something called as maxillomandibular complex rotation, or MMC. This is ideally 100% suitable case for jaw surgery. Because if you look at it, both the maxilla and mandible are kind of unison and they are moved together towards the right-hand side of the patient. That means that the upper canting is not more skewed to one side, which is on the left-hand side, and the mandible is not skewed on the left-hand side. So in those cases, and also I can fairly visualize that his teeth are pretty much well aligned. They don't have massive crowding there, and also the teeth are pretty much upright in his alveolar bone. So those kind of gives me a clear indication that this could be a good maxillomandibular complex rotation, that you take it as one unit and then rotate it along with it, so that it becomes an ideal case for surgery first.
All right. So next, when you see an open bite post-surgery, what runs through your mind? How are you going to manage it?
Take an X-ray, as simple as 2D OPG, or if you catch hold of CBCT, look at the head of the condyle positioning. I'm 100% sure in these kind of cases, the head of the condyle would have moved forward. It will be almost hitting the articular eminence. I cannot go wrong in this kind of cases. The open bite is a very classic indication that the head of the condyle was not lax enough when they were trying to do an IMF or when they were trying to plate it. Somebody was really holding it and then they were kind of plating it. So if you take an OPG, you'll realize that the head of the condyle is kind of out of the glenoid fossa. That's if they ruled out that. If you don't see any other problem there, look for the stretch of the muscles, how much of the mandible has been moved. I take it as a rule that if you move more than 6 millimeters, whether it's setback or an advancement, there is a high chances that the stretch of the muscles will be trying to go back to their original place. So 2 places. One, the head of the condyle. If that's ruled out, there's no problem there. Stretch of the soft tissues to look at whether you need to go back and kind of release some of the masseter muscle sling there, or you really need to think about whether you did a single jaw surgery where it was a double jaw surgery where you can do a half and half correction in order to kind of balance that large movement of one jaw only.
All right. So now, has the use of temporary anchorage devices increased in treating the post-surgical complications?
I rarely use it in terms of the application of TADs post-surgery. But having said that, my own experience of TAD is probably we were looking at correction of the cant, and the cant correction was not 100% achievable for some technical reasons in surgery first. Like for example, the maxilla was massively canted, and the surgeon would like to place it with all the surgical correction, but there were limitations for it in terms of how much the maxilla could be impacted, because the bone available from the piriform aperture to that of the alveolus of the canine was not enough for them to kind of impact or remove chunk of bone. So they left it at 6 millimeters need to be impacted, and then they left it at 4. That means you're left with 2 millimeters of cant correction. So in those kind of cases, a TAD comes into a great refuge, if I may, where you can apply those TAD and further correct that residual cant that was left untreated during surgery first.
Yeah. I'm going to show the next image.
Right.
Virtual surgical planning. What is your take on it? This is a planning picture.
Okay.
So it just depicts the virtual surgical planning workflow. Like during our initial days of training, we never had the luxury of a virtual surgical planning. Like you'll have to see the models articulated, do the set, and imaginarily reconstruct the 3D. But now you have everything on the screen. So what are your thoughts about the virtual surgical planning?
I think it offers a very good understanding of three-dimensional view. I mean, given the way I started using virtual surgical planning software since 2010-11. That was the day when we used to have like 3 hours at least to reconstruct the image, and then it used to take forever to kind of move from one place to another. From there, to fast forward 2026, you can just press a button, you can do a lot many things. That means that the understanding of the algorithm that they have created has very much improved. So surgery first or conventional surgery, virtual surgical planning does help you plan better, or at least understand the three-dimensional structures rather than having a 2D view, or even go back to the old days of analog planning of cutting the models and then putting it on the articulator and then viewing it how it has to be.
All right, so here's the next picture. Yeah, so we have the wafer surgery and the waferless. I'd like to, know your thoughts about between wafer surgery and waferless surgery.
Right. I think it's fair to say that it's a bit of an evolution or a spin-off from the wafer surgeries, because by and large we used to use occlusion as a way of understanding where should be your skeletal structures should be placed in a final position, right? That's called wafer. You use occlusion as a guide and then move the skeletal structures. Well, I think why it was done is because the teeth are already there. You can take an impression and then make a wafer and then move it. So now the technology has improved so much that you can actually take a printout, put it in a STL file and then hold the skeletal structures, or you can actually plan it on the planner and then make the skeletal itself, the unmovable skeletal part, as the stable structure, and then give a command to your 3D printer so that it will move the maxilla mandible how much it has to move, and then use a kind of that has become eventually called as a waferless surgery or occlusion-less surgery. I think it's a spin-off where, as technology kind of enables us to visualize what we have already dreamt about, it gives you more options to explore, and this is a good advancement in terms of what technology can bring to the table.
All right. So the next picture would be AI assisted planning. So are you excited, skeptical, or cautiously optimistic?
I'm not excited at the moment. Why? Because the algorithms are rubbish. I've used that, and the AI can tell you a lot many things, which are like, I mean, I'm not blaming the AI. It's a large language model. It's trying to figure out what's the past data that has already been there, and it's trying to process it and spit out some numbers. AI can become a robust way of assisting you as a professional in the near future, but at the moment, don't even go and think about typing something and getting the right answer. It might throw you out of your office if you go and say that the AI is telling you this and I will offer this to the patient. Now, it's criminally inhumane to even think about in those terms. Cautiously optimistic, maybe in the future, but AI may not be the right answer for surgeries, let alone any kind of orthodontic treatment.
So, we had a wonderful discussion about the clinical aspects of surgery first orthodontic approach, and we have more in our bag. So, we are going to talk about the academic part of it, the research part of it, and of course, a little bit of sneak peek into the chef's life of Dr. Narayan. So, for all of these, please stay tuned for the part 2, and it will be released on August 7th, 2026. Until then, it is Dr. Srirengalakshmi signing off.